In this video, let us solve some clinical cases relating to hemostasis and blood coagulation. Case 1. A young woman complains of recurrent bleeding from the nose. There is a family history of nosebleed. On examination, there is a mild pallor, no icterus, no lymph node enlargement, no clubbing. Cardiac and respiratory systems are normal. Blood investigation revealed bleeding time 16 minutes prolonged. Reticulocytes increased 8%. Platelet count 3,15,000. Prolonged activated partial thromboplastin time (APTT). Plasma factor 8 activity is reduced. Plasma von Willebrand factor is below normal. Which of the following is the cause of bleeding in this woman? The case obviously suggests a deficiency of factor 8 combined with the deficiency of von Willebrand factor. So you can straight away go to the diagnosis. The von Willebrand disease characterized by abnormal platelet addition, plug formation, as well as clotting disorders. So what causes the bleeding? Defective platelet addition and aggregation, abnormal initiation of the intrinsic pathway of coagulation, increased release of thromboxane A2, deficient clot retraction. A, obviously, defective platelet addition and aggregation. Mainly von Willebrand factor is involved in the addition. Platelet gets adhered to the damaged endothelium collagen via the receptors, platelet receptor and von Willebrand factor, and followed by the aggregation. This is the first step in the platelet plug formation, temporary hemostatic plug. So it will be affected, therefore the bleeding time is prolonged. Von Willebrand factor also maintains the factor 8 anti-hemophilic factor in the plasma. There will be defects in the intrinsic pathway of coagulation, but does not affect the initiation. Initiation does not involve factor 8. Increased release of thromboxane A2, it's unlikely. It's not, if at all, it's decreased, but it doesn't. It's not an answer. Deficient clot retraction, platelet count is normal, almost normal. 3,15,000, 350,000, 15,000. Reticulocytes are slightly increased. It doesn't matter. So A, hemostasis case 2. 20-year-old patient with a family history of hemorrhagic disorder is admitted for administration of freeze-dried concentrate of factor 8 for a recent onset of bleeding episode. His clotting time and bleeding time are found to be prolonged. Activated partial thromboplastin time (APTT) is prolonged. Platelet count 2,40,000 per cubic millimeter. Which of the following is lower than normal in this patient's plasma? In addition to reduced factor 8 activity, platelet factor 3, von Willebrand factor, ADP, thromboxane A2. This is almost extension of the previous question. If you look at the case, the person required factor 8 for the hemorrhage or hemorrhagic disorder, bleeding disorder. Clotting time, bleeding time, both prolonged, so it's most likely to be von Willebrand disease. Deficiency of von Willebrand factor is the correct answer. Platelet count is still normal here. APTT is prolonged because of the clotting. The coagulation pathway is affected because of factor 8 deficiency. The explanation for case 1 and 2. Von Willebrand factor binds platelet receptors to the collagen and facilitates platelet addition. Von Willebrand factor also binds factor 8 anti-hemophilic factor and regulates his plasma level. deficiency of one Willebrand factor causes defective platelet plug formation. Factor 8 deficiency leads to defective amplification and propagation of the intrinsic pathway of coagulation. The initiation is not affected. This will result in prolonged bleeding time as well as prolonged APTT and prolonged clotting time. Case 3. A 42-year-old woman who has been bedridden for a long time for her illness develops sudden onset of breathlessness and chest pain. A diagnosis of pulmonary embolism is arrived at. She is administered intravenous heparin in addition to oxygen to relieve hypoxia. Which of the following is the rationale of heparin therapy? She has an embolism, that is thromboembolism, thrombosis, pulmonary thrombosis. Now you have to avoid that thrombosis. Acceleration of protease inhibitor action of antithrombin. Activation of plasminogen to plasmin by binding of heparin. Prevention of polymerization of fibrin monomers. Inhibition of thrombin thrombomodulin complex at the endothelial surface. Which of these is the heparin action in preventing thrombosis, intravascular thrombosis? Heparin binds to antithrombin 3 and increases the protease inhibitor action of that antithrombin 3. That is the action of heparin. Other things are not the actions of heparin. Plasminogen, plasmin, polymerization, fibrin, thrombin, thrombo, they're all not actions of heparin. Heparin is an anticoagulant, both in vitro, in vivo anticoagulant, effective both in vivo and in vitro. Combines with antithrombin 3, enhances its protease inhibitor action, and ultimately inactivates several clotting factors, serine proteases, which are involved in both intrinsic and common pathways. It is prothrombin, factor 10, factor 12, and factor 11. Mainly factor prothrombin and factor 10. So they are involved in intrinsic common pathways. Case 4. A 45-year-old man is admitted to the emergency for extreme fatigue, loss of appetite, and loss of weight. He also complains of vague abdominal pain and nausea. He reports few episodes of epistaxis, that is uncontrolled nosebleed. Physical examination reveals mild jaundice and enlarged liver. The prothrombin time is 18 seconds. Reference is 12 to 14 seconds, slightly increased. APTT 45 seconds, slightly increased. Reference 25 to 35 seconds. Serum bilirubin elevated 3.5 mg per deciliter. Serum aminotransferases, both ALT and AST, are elevated. AG ratio, albumin globulin ratio, is reduced. Which of the following is the most probable cause of the bleeding episodes in this case? A. Decreased synthesis of serine proteases of coagulation system. Vitamin K deficiency due to biliary obstruction. Defective formation of platelet plug, or is it decreased production of von Willebrand factor? Of course, all these will lead to defective hemostatic processes. We'll have to pick up which is the cause here. This looks like a problem with the liver. Liver enzymes, enzymes are elevated, AG ratio is reduced, bilirubin is elevated. Both PT and APTT are prolonged. There's a mild jaundice, enlarged liver, and the bleeding tendencies. And some of the symptoms of vague symptoms of hepatic failure, fatigue, loss of weight, abdominal pain, nausea. So it looks like problem in the liver. Liver synthesizes clotting factor. So it must be the decreased synthesis of serine proteases. Serine proteases are the factors which break the protein. They are proteolytic substances. They are also called proserine proteases of the coagulation system. The explanation is this. The liver is the major site for synthesis of several clotting factors, mainly prothrombin. Bleeding episodes in this case are most likely due to decreased synthesis of these serine proteases of coagulation system. Vitamin K deficiency also causes deficiency of clotting factor, that is 2, 7, 9 and 10. But there is no evidence of biliary obstruction vitamin K deficiency in this case. The co-synthesis of these factors are affected, but without the vitamin K deficiency. Liver synthesis all these factors. Vitamin K is necessary for some of the activation of these factors in the liver, but there is no deficiency of vitamin K in this case. The liver dysfunction does not affect platelet count or platelet function, so the third option is not correct. One Willebrand factor deficiency can be ruled out because endothelial cells and not platelets form the von Willebrand factor. So the option is first. Case 5. A 21-year-old patient has frequent bleeding episodes with trivial injury. The bleeding time and platelet count are normal. APTT is found to be prolonged. Prothrombin time is within normal limits. Which of the following pathways or processes in the hemostatic process must be normal in this case? The extrinsic pathway and the primary hemostatic blood formation is option A. Option B is intrinsic pathway leading to the formation of prothrombin activator, or is it both intrinsic and extrinsic pathways, or is it only intrinsic pathway by contact activation? You have to choose the correct answer for this question. Here if you look at the case, the bleeding time, platelet counts are normal. So platelet plug formation is normal. So that must be normal. So option A has that primary hemostatic blood formation must be normal. Let us see whether extrinsic pathway is normal. Yes, because the PT prothrombin time is normal. So prothrombin time assesses extrinsic pathway. So A must be the correct answer. Let's look into the other option. Intrinsic pathway leading to the formation of prothrombin is not the correct answer because APTT is prolonged. APTT assesses the intrinsic pathway and the common pathway. Since APTT is prolonged, intrinsic pathway must be affected. Both extrinsic and intrinsic pathways, no. Extrinsic pathway we have already said it is normal. C is also not correct answer. Is it intrinsic pathway by contact activation? No, it's not the correct. Intrinsic pathway by any means is abnormal because APTT is prolonged. APTT assesses intrinsic and common pathways, whereas prothrombin time assesses extrinsic pathway and common pathway. Prothrombin time is based on the assessing of the vitamin K dependent factors mainly. So they are all involved in the extrinsic pathway. So prothrombin time is a very good guide for therapy with oral anticoagulants. warfarin, dicumarol, because they're all vitamin K antagonists. This is A is the answer.